AMS Clinical, AMS Clinical Club. This is the second program the AMS is conducting this month. We started with cyclathon. We organized the cyclathon in association with IM at Trivandrum branch and the National Action Council. And it was a huge success. That was on the World Health Day. And this is the second program. And today, we're having a session on some two interesting cases in pulmonology. A very interesting, two simple cases. That's what I could make out. Two interesting cases, but how to manage such cases once it comes to our ER. This will be a very useful session for all of us who are seeing pulmonary respiratory cases. And the speaker is very familiar to all of us, Dr. Ajoy Samuel Mammen. He's a senior consultant in pulmonary, critical care, and sleep medicine in Cosmopolitan Hospital, Trivandrum. This is the second time he's participating in our AMS program. First session was on a recent advances session. That was a very fantastic academic program. And he's a very good academician and a nice human being. I welcome you, Dr. Ajoy.
Thank you, sir. Thank you.
I think I'll trouble you again. Okay,
sir. Okay, sir. Thank you for those nice words.
One second. And I will, we have our president, Dr. G.S. Vijayakrishnan here. He's busy. He has got 2 more programs today, I think. And he is always makes it a point to attend all the AMS programs to support us. And welcome, Dr. G.S. Vijayakrishnan.
Thank you, Pradeep, sir.
Yeah, and
nothing
notice that one of our senior national leaders, Dr. Srijit Kumar, has joined. And I'm really glad that he is participating in our AMS programs. Welcome, Dr. Srijit Kumar.
Well, thank you very much. I joined especially because Ajoy is our very loving son. He's son of Dr. Susan Samuel, who is our guide and mentor and a very loving leader of IM.
Okay. And now we have some interesting sessions. Our next session will be on 17th. Though it should be named the AMS Recent Advances session. It is named as AMS Generation Next. I'm really thrilled to present a next generation faculty. A PG student, very enthusiastic, very dynamic PG student with a very good topic on recent advances. I welcome you all to attend the session on 17th, 8 o'clock, to encourage the person. And we are starting a new experiment as well. We want to introduce more faculties to our academic programs. So please join our next program that is on 17th. We have 4 more programs in our pipeline for this month. And our convener, Dr. Anand Marthandapillai, there's no need to welcome him. He's a part of my family and our AMS family. And I noticed that our district committee convener, Dr. Srijit, has joined. Welcome, Dr. Srijit. Thank you for joining. And,
thank you, sir. Thank you, sir. Thank you.
And I welcome all the senior leaders, all the participants. Please do come and attend all the AMS programs. That's a way to encourage us. That's what we need very badly. And thank you, welcome all. And I request Dr. Vijayakrishnan to say a few words.
Respected AMS Chairman of IM at Trivandrum, Dr. Pradeep Kadangur, sir. Respected Srijit Kumar, sir. Senior leaders and dear faculty. AMS കഴിഞ്ഞ 6 മാസമായി 4 മാസമായി ഒരുപാട് പ്രോഗ്രാംസ് ഓരോ മാസം 3-4 പ്രോഗ്രാം വെച്ച് തന്നെ നമുക്ക് ഇന്ത്യൻ മെഡിക്കൽ അസോസിയേഷൻ ട്രിവാൻഡ്രം ബ്രാഞ്ചിൽ ചെയ്യാൻ സാധിക്കുന്നുണ്ട്. എല്ലാം ഡിഫറെന്റ് രീതിയിലുള്ള അക്കാഡമിക് പ്രോഗ്രാംസ് ആണ് നമുക്ക് കണ്ടക്ട് ചെയ്യാൻ സാധിക്കുന്നത്. ഇനി ഈ മാസം തന്നെ 28-ന് നമ്മുടെ അടുത്തൊരു മെഗാ പ്രോഗ്രാം കൂടി വരുന്നുണ്ട്, ഹോട്ടലിൽ വെച്ച് നടക്കുന്നുണ്ട്. എല്ലാവിധ പ്രോഗ്രാമിലും എല്ലാ ആശംസകളും നേരുകയാണ്. അതുപോലെ തന്നെ നമുക്ക് ഇനിയും പാർട്ടിസിപ്പേഷൻ കുറച്ചുകൂടെ കൂട്ടേണ്ടതുണ്ട്. കുറച്ച് ആൾക്കാർ കൂടി വരുന്നുണ്ട്. വ്യക്തമായ രീതിയിൽ നമുക്ക് ഒരു പബ്ലിസിറ്റിയോട് കൊടുത്തുകൊണ്ട് അടുത്ത പ്രോഗ്രാംസ് നമുക്ക് മുന്നേറിക്കൊണ്ട് മുമ്പോട്ട് പോകാം. കൂടുതൽ ദീർഘിപ്പിക്കത്തില്ല. എല്ലാവിധ ആശംസകളും ഫാക്കൽറ്റിക്ക് പ്രത്യേകം നന്ദി രേഖപ്പെടുത്തിക്കൊണ്ട് നിർത്തുന്നു. താങ്ക് യു.
Now I request Dr. Ajoy Samuel Mammen to present the topic. Welcome, Dr.
Thank you, sir. Thank you for those kind words of introduction. Hope I'm audible to all of you.
Yes, very much.
Yeah. So first of all, I want to say sorry because I was a bit late because I got held up in the hospital OPD for some time. So without much delay, I'm going to start the topic. The topic for discussion is interesting cases in pulmonary critical care medicine. The thing I want to share with all of you is we see a lot of cases in our OPDs, day in and out. So we tend to, in our busy OPDs, we tend to miss certain findings. So these two cases are very simple cases because I'm not going to talk about very hi-fi cases in pulmonology, critical care like the LAMB, LCH and all. It won't be much useful because we as pulmonologists, we hardly see such cases once in a lifetime and all. So these are two common cases which you might encounter in your emergency room. And I don't want anyone to go or miss these findings because it will cost the life of your patient. So going straight to the topic. So first of all, I like to thank the IMA Swing for giving me an opportunity. I like to thank all the senior leaders of the IMA for taking their time to attend this session. So going straight into the topic. Is my slides moving, sir?
Sorry?
Yeah, my slides are moving, right, sir?
Yeah. Yes, sir.
Yeah, the case one, this is the first case. This case came to our OPD or emergency room. In fact, he was a 21-year-old male. He was a medical student studying first year MBBS student. He had no previous comorbidities. He presented to the emergency room with fever of 1 week duration, cough of 1 week duration. And he was on oral antibiotics from the local hospital. So these cases you all see in your emergency room. He was started on IV antibiotics from that local hospital. He was taking the first day, day 1. He presented to our ER with acute onset of breathlessness of 30 minutes duration. And there is no history of chest pain, no history of foreign body aspiration, no history of asthma, allergies, or COVID-19 infection. His mother, who was a bystander, gave history of weight loss. And the mother said that he was staying in the hostel for the past 3 months. So he was a first year MBBS student, and she was attributing to that fact that he was losing weight. On examination, he was conscious oriented. He was tachypneic. Accessory muscles of respiration was working. Intercostal indrawing. Bilateral supraclavicular fossa fullness was there. So these findings, I advise everyone to examine these findings, whether the patient is tachypneic, whether the accessory muscles are working or not. So when we see such cases, we know something is definitely wrong with the patient. Just on auscultation, chest was having bilateral rhongi, and there was an inspiratory stridor. So what do you mean by inspiratory stridor? So when you hear an inspiratory stridor, what do you mean by stridor? Stridor means a noisy breathing you hear while you are examining the patient. And if it is towards the inspiratory phase, we say it's an inspiratory stridor. So when we hear an inspiratory stridor, what things should come to your mind? It should be either an upper airway problem. His vitals was, pulse rate was 134, that is he was having tachycardia. BP was on the highest side, 160/90. His saturation was 60% on room air. So he was in respiratory distress. And his sugars was around 165 milligram per deciliter. His ABG showed pH of 7.15, PCO2 of 87.6, PaO2 of 89, and bicarbonate of 31. So from this ABG, what is your inference? It's definitely a type 2 respiratory failure. What do you mean type 2 means? The carbon dioxide will increase, the oxygen may or may not increase. So this ABG was taken with oxygen support. That is why his PaO2 is around 89. But his PCO2 was climbing up, his pH was coming down to 7.15. So when you are the consultant, when you're resident or when your duty doctor and the casualty calls you up, in the night saying that, okay, we have a patient, 21-year-old with such and such complaint, ABG is this. What will be your next step? Next step will be, since carbon dioxide is high, we have to initiate a artificial or NIV, that is a non-invasive ventilation. So this patient was seen by junior resident at 8:50 p.m. and they are called the junior consultant on call. He had seen the case at 9 p.m. At 9:10 p.m., since we were taking rounds during that time, the senior consultant was around and he came and we saw the case. So since it was a 21-year-old, he was in respiratory distress. The senior consultant himself came and saw the case. Luckily, he was there. Before the senior consultant came, the patient was started on oxygen support. Adrenaline injection was administered because we were suspecting, or the JC and the JR was suspecting a kind of anaphylaxis reaction because he was on oral antibiotics. He was given IV antibiotic. Later on, he'd have all these problems. Intravenous steroid was also administered and nebulizations were given. Next step is, as I've already said, it's a case of type 2 respiratory failure. So NIV or BiPAP, bi-level positive airway pressure, is a modality of choice. But there is always a but. I always remember my mentor, Dr. P. Ravindran sir, who always says that the medicine keeps on changing. So you have to again look out for you have to keep your mind open. You have to have an open mind before you come to a diagnosis. So on the eyes of a senior consultant, there was a disparity in the stridor heard. This is the importance of knowing your clinical signs, how to pick up your clinical signs. It was not purely inspiratory stridor. It was a biphasic stridor. So what you mean by biphasic means the stridor is present both in inspiration as well as expiration. That is biphasic stridor. So when you hear a biphasic stridor, your level of etiology or the pathology changes. So I will just say that stridors are 3 types: inspiratory, biphasic, or expiratory. If it is an inspiratory stridor, the pathology will be in the upper airway, that is above the level of the vocal cords. If it is an expiratory stridor, it is in the level of a bronchus, that's the lower airway, or a cervical trachea. And if it is a biphasic, it can be at the level of glottis, at the level of vocal cord, or subglottic part. So we were able to find out that it was a biphasic stridor. So we ordered an emergency chest X-ray. This was an X-ray. So if you look at this X-ray, whenever you look at the X-ray, all will be looking at the lung parenchyma. So the lung parenchyma is okay. There's no much problem because there is no pneumothorax. There is also minimal infiltrates. Like RA size is a bit dilated. So is there any finding you can pick for the cause? So since we have heard a biphasic stridor, our main aim of looking at an X-ray will be in this part. That is in the thoracic region or the cervical part of the trachea. So this was an enlarged way. I hope it is visible. You see there is a critical narrowing of the trachea in the cervical part. So there is something which is obstructing the trachea, which is causing, that is, the lesion is below the level of the vocal cords. So the ENT surgeon was called on to rule out the vocal cord pathology. 9:45 p.m., the patient becomes disoriented. 10 p.m., he becomes more dyspneic. 10 p.m., the ENT surgeon did a flexible video laryngoscope. And by 10:20 p.m., he reported that the vocal cords were normal and mobile. So now you have a case, like it's a 21-year-old boy who is becoming dyspneic. When came to the ER, now he is becoming disoriented. The parents, as a parent, you will become more restless. The mother was getting agitated. All confusions were going on in the emergency room. So now the question is, will BiPAP help this patient? Or should we do the stenting? Because we know it is below the level of vocal cord. Should we do the stenting of the lower airway? Or will tracheostomy help? So when you put a BiPAP, what happens? It pushes the air into the airway. So if there is an obstruction below the level of vocal cord, apart from the bronchospasm, BiPAP will not be helpful to the patient. Should we do stenting? Stenting is not an emergency. It cannot be done on an emergency basis. Will tracheostomy. So if it is a fixed obstruction, your tracheostomy will not be going to help the patient. So we did a repeat ABG by 11 p.m. It showed improvement in ABG. 11:10 p.m. emergency CT test was done. And this was the image from the CT chest. It showed a mass obstructing the cervical part of the trachea. You see the mass encircling the trachea, causing the critical narrowing of the trachea. So we need a diagnosis. So we need to secure the airway as early as possible. So as I've said in the second slide, there was fullness of supraclavicular fossa. So there was lymphadenopathy. FNAC, since the patient was, we were planning for FNAC on the next day. To secure the airway, we have put a pediatric ET tube was put. Patient was stabilized by 11:20 p.m. That means it took 2.5 hours taken to stabilize the patient. So this was a young patient. If your diagnosis is going wrong, that is, if you have put the patient on BiPAP based on your phone call,
Cannot hear.
hello, sir.
Yeah.
Yeah, I got disconnected in between. I'll just share my screen right now.
Yeah. Sorry, looks like there's some technical issues. We'll start the session very soon. Please wait.
Sir, is my screen visible now?
Yeah, but no, yeah, fine. Yeah.
Okay. Yeah. So I was talking about, I think, yeah, this was an X-ray, right?
Yeah.
Yeah. Yeah. So now the question is, so we saw that it was a large mass obstructing the lesion. Is an image visible, sir?
Yeah, it's visible, but you can enlarge that slide.
Slide. Okay.
Yeah.
Okay. Now it's visible, sir?
It's visible, but it's, it's very, that slide is very small, so you can enlarge it.
Okay, sir. Just a moment.
2 or 3 slides are visible at the same time.
Together, right. Okay, sir. So now it's okay, right, sir?
Yeah, fine, yeah.
Yeah, okay, sir. So as I was telling, okay, we saw in the second slide, there was a fullness of supraclavicular fossa, as I was telling in the earlier slides. So there was lymphadenopathy, and FNAC was planned for the next day. So meanwhile, to secure the airway, the pediatric ET tube was put. The patient was stabilized by 11:20 p.m. So it almost took 2.5 hours for the patient to get stabilized. So this is very crucial, because when such a patient comes to your emergency room with all these problems, you have to think in the right way. So FNAC was done on the next day, and the diagnosis was a Hodgkin's lymphoma, nodular sclerosis type. So this explains the loss of weight he was having, and he was started on ABVD regime from RCC, and the patient was extubated second day after starting the treatment. So what all could have gone wrong? So this is the most important thing. If NIV or BiPAP was initiated, what will happen? It would have aggravated the problem. Okay, so aggravation of the problem means, since it is a lower airway problem, it would have caused airway laceration, and subcutaneous and mediastinal emphysema would have happened. So if you were on call and your duty doctor or JR calls you, and if you have advised to start a BiPAP, it would have caused all these problems, and we have lost the patient, because subcutaneous emphysema, mediastinal emphysema, as you all know, it's a very deadly thing. And if tracheostomy was done, since the lesion was subglottic, and below the level of vocal cord, but it was a fixed obstruction, the tumor was encircling the whole trachea. So it would also have caused airway laceration, and it would have produced a grave outcome. So the take-home points from this case is that all striders may not be due to upper airway problem. So this is very important, because when you hear a stridor, you have to face the stridor. We always tell to our residents to face the stridor, whether it's inspiratory, biphasic, or expiratory. Look and listen to the stridor. And based on the stridor, you classify where is the pathology. And investigation of choice should be prioritized. So here in this case, X-ray was taken, ABG was done, and CT chest was done. That was investigation of choice to clinch the diagnosis. That we came to know it was a fixed obstruction. It was a tumor which is causing the fixed obstruction of the cervical part of the trachea. So these all things should be kept in your mind when you see another case of a respiratory distress in your ER room. Coming to the case 2, this is another simple case, a 56-year-old male. He is a known case of bronchial asthma, diabetic, allergic rhinitis. He came with fever, cough, severe chest pain on the left side. His vitals were, pulse rate was 98. BP was around 140/90. Saturation was around 92% on room air. ECG was within normal limits. So he was having severe left side chest pain. So this was the X-ray taken. So can anyone find any abnormality in this X-ray? So whenever you look at the X-ray, you look at the lung parenchyma first. So if you see that on the right side, you can see the lung markings are clearly visible in the periphery. But if you see on the left side, there are no lung markings. So it is a hyperlucency, and you can see that near the left paracardiac, there is a shadow. So this is a case of left-sided pneumothorax. So whenever we say it's a pneumothorax, we have to find out the visceral pleural line, and there is an absent lung marking. So this was causing the severe left-sided chest pain. And whenever you see pneumothorax, you always have to know whether it is causing a tension pneumothorax. Whether it is causing tension, whether it is pushing the mediastinum to the opposite side. In this X-ray, the mediastinum or the trachea is central, the mediastinum is not pushed. That is why the patient was not that much in respiratory distress. Pulmonology consultation was advised, a detailed history was taken. There is no history of trauma, no prior illnesses. chest X-ray showed no evidence of rib fracture. So whenever you see a case of pneumothorax, you have to find out what has caused the air leak. Bronchial asthma history was not adequate, and he is not a smoker. So the diagnosis is PSP. We say it is a primary spontaneous pneumothorax. Spontaneous means on its own, the pneumothorax have occurred, and it's a primary. Primary means the patient was having no other earlier respiratory illnesses. So the management, according to guidelines, primary spontaneous pneumothorax, if it is a large pneumothorax, that is more than 2 centimeters from the periphery, if the air column is there, you need a ICD insertion. And here we advise a ICD insertion, but what happened is that the patient was not willing for an ICD insertion. And so the decision for simple aspiration with 16 gauge cannula was planned. So I hope how many of you, if you have done an aspiration of a pneumothorax, I know that you will be having this knowledge. That is aspiration of a pneumothorax. What are the challenges you will encounter? First one is we have to properly position and mark the site of aspiration, because since it is air, the air will move about. That is, if the patient lies supine, the air will be occupying the anterior part of the chest wall. If the patient lies erect or in a semi-recumbent position, the air tends to collect towards the upper part of the, or towards the apex of the lung. So you have to rule out bullous lung disease before you put an ICD or before you aspirate. Because if it is a bullous lung disease, and if you put an ICD, and if the ICD goes into one of the bullae, you're going to create a bronchopleural fistula. And then you won't be able to take out the ICD. So on aspirating air, once you put in the needle, you get into the pleural cavity, you have, when you're aspirating the air can come from outside the lung parenchyma or even from the lung. This is a very tricky situation. So the chance for injury to other nearby organs during such aspiration is very high. So how to confirm? This everyone should be knowing. There is a point of care ultrasound. So when you put an ultrasound machine or point of care ultrasound machine on the chest wall on the affected side, you will see that there is no sliding pleural sign will be there. So the sliding pleural sign will be absent in such cases, and the barcode sign will be there, or stratosphere sign will be there in a pneumothorax. So aspiration should be of pneumothorax should be using underwater seal. In this case, we aspirate around 800 ml of air we aspirated. We have to quantify it. Patient symptoms got partially resolved, and repeat chest X-ray was taken. And this was a repeat chest X-ray. You see that there is partial expansion of the lung, but still there is pneumothorax. So we put the patient on a high flow oxygen therapy. So the principle behind high flow oxygen therapy is the diffusion defect or diffusion principle. That is, your oxygen molecule will displace the nitrogen in the pneumothorax, and this oxygen will get absorbed by the subcutaneous tissue, and it will help in resolution of the pneumothorax. But on the next day, his pneumothorax was increased, and he was referred for ICD insertion. So the take-home points from this case discussion is point of care ultrasonography is needed in every ICU setup. The reason why I am telling is 5 years back, a case was filed against a doctor, an experienced doctor who was a senior pulmonologist. A patient came to the emergency room. He was having left side massive effusion. He was having CLD, chronic liver disease with portal hypertension with splenomegaly. The patient was in so much of respiratory distress. So letting out the fluid will be helping the patient. So the senior pulmonologist, out of his kindness or out of his empathy, he put in a needle into the left side of the chest cavity and he aspirated. And at that time, blood was only coming. So he thought it was a hemothorax. But there was an underlying collapse. The diaphragm was pulled up. The spleen, he injured the spleen while aspiration. And the patient died after 2 days. Because the patient was having other comorbidities, but the bystanders as well as relatives, they filed a case against the doctor saying that it is because of his aspiration that the patient succumbed to death. And the court has fined around 25 to 30 lakhs against the doctor. Only reason for filing or putting the fine is the point of care ultrasound was available in that hospital. And why he didn't use the point of care ultrasonography before putting in the needle. So even if you are having a point of care ultrasound, and if you are not knowing how to do it, better learn it, because in this era, it's very important to know how to do a screening ultrasonography, as well as even if you are not doing, if you are aspirating, just put in your notes that under USC guidance, you are going to aspirate. Because if at all a legal issue comes, you will be safe. So you should be knowing how to do a screening echo and FAST. FAST means focused abdominal sonographic technique. And basic lung imaging should be known. USC guided procedures should be the need of the hour, and it is mandatory. That is, whenever you're doing a pleural fluid aspiration, whenever you're doing a central line insertion, HD catheter insertion, it should be done under USC guidance. And even if you're not aware, or if you're not knowing how to use ultrasonography, there are many workshops coming up so that you get to know how to do it. And even if you're not doing it, you put in the notes that under USC guidance, you are doing all these things. So if anything goes wrong, you won't be at fault in the eyes of the court or in the legal setup. So these are the two simple cases. One is a Strider case where a mass was obstructing the trachea. Another was also a case of respiratory distress. But since it is a pneumothorax, you need to know when to put an ICD, because I get so many consultations, like for a mild pneumothorax to put an ICD and all, you should know when you should put an ICD, whether the patient needs a simple aspiration, or before putting an ICD, what all things should be done. So these are the two simple cases which can come to your emergency room. And if you are taking in the wrong decision, it can cost the life of the patient. So thank you once again. Sorry for the technical glitch, because I lost connection in between. And also I was a bit late for today's talk also. Thank you again for your kind attention for the talk. Thank you, sir.
Okay. Any questions? Dr. Ajoy, there is a request to show that first X-ray again.
First X-ray, okay, sir.
Yeah.
So this was the first X-ray. So I hope you can see this. So there's a critical narrowing is there. So I'll just draw it and show you. So I hope you are able to visualize the critical narrowing.
Yes. Yes.
So this was the trachea. This was the narrowing. So there was a mass which was obstructing it. Unless otherwise you take a CT, you won't be able to see. And there was a fullness of that. There was multiple lymph nodes in the supraclavicular fossa also. So this was the first X-ray.
Okay. Okay.
So the thing is that whenever we see a case, or whenever you hear your resident calling up in the night and telling all your clinical findings, always double check whether the findings are correct or not. Either ask him again, are you sure that this is the case? Or if you are in doubt, you can ask your junior consultant to see the case or by himself or herself, and then assert and take decisions. Because in the first case, if the BiPAP was initiated, luckily for that boy, the senior consultant was around by 9:10. The evening rounds was already being taken. The senior consultant was around, and see, even if a resident or duty doctor, it doesn't matter whether it's a senior consultant. If you are having that clinical acumen, then you'll be able to pick up cases. In this era, I see students who are less relying on clinical science. Clinical science are very important. Apart from your X-ray reading, the CT scan, if you are able to pick up this clinical sign in your OPD, it will change your management. So that is a take-home message that even in your OPD, if you're able to pick up the certain clinical signs, it will be helpful for the patient.
Any more questions?
Sorry, once again, when everything goes wrong, it goes wrong in all the way. Today it was a wrong day for me.
But the session was very good, very useful. This is exactly what we need. So giving tips to so many, you give so many information, very good, very useful tips. That was excellent.
Yes, sir. Because many of the duty doctors who come to our OPD always ask how to learn this ultrasonography, this USC chest and all. There are many workshops happening throughout Kerala and as well as in India. You attend one of these workshops, you come back to your hospital, because this is the way I learned. I attended 3 or 4 workshops. I come back to my ICU. I do screening echo for every patient, every normal patient does screening echo during those times. And every elderly patient or every patient will be happy only that I will say, heart you learn the normal echo first. Then only you will be able to pick out. Because in a case of pulmonary embolism, this is a very tricky situation. When a pulmonary embolism happens, and if the cardiologist is not around, if you're able to do a screening echo, if you're able to see that there is a RV strain, there is a McConnell sign, then you can thrombolize the patient based on that finding. But if you're not knowing how to do a screening echo, if your cardiologist is not around, then you might lose a patient. We had a case. We had a 25-year-old girl who presented to the ER with acute respiratory distress. She shifted to the HDU. She was not responding to BiPAP. X-ray was normal. There was an enlarged pulmonary trunk. We were suspecting pulmonary embolism. D-dimer will take 2 hours for the result to come. She was not stable for shifting to CT. Her BP was falling. We did a screening echo. RV strain was established. We documented it. We consulted the cardiologist and we thrombolized the patient. The patient was saved. It was a 25-year-old girl. Now also she comes for review. And the reason was she was a pure vegetarian. I am not complaining about this diet and all. But since she was a pure vegetarian, she was having vitamin B12 deficiency. She was having serum hyperhomocystinemia, which was the cause for the clot formation in her pulmonary artery. We published that case also.
There's one more question. How was the amount of air aspirated in pneumo quantified?
Yeah, that's a very nice question, which is if I am so when you're aspirating air, you can't see the air. Okay, when you aspirate in the aspiration syringe, you see certain fumes coming, or fumes of mist formation you see. But I always say you aspirate with the underwater seal, or you take a 10 ml normal saline, you aspirate it. So once you pull the piston, we usually aspirate with 20 ml syringe or 50 ml syringe. So when you pull the piston maximum, it will be quantified as 20 ml. Then you, through the 3-way valve, you push out the air. Again, you pull out this piston. So by that technically, you'll be able to quantify the air aspirated. And by rule, it is only up to 500 to 1 liter of air should be aspirated. And if the patient has any symptoms, like if the chest pain is increasing, if the patient is coughing, stop. Whether it is pleural effusion or a pneumothorax, you have to stop your aspiration. You have to then stop the procedure, repeat the X-ray, then only you proceed.
Okay. And you said that you used a pediatric ET tube.
ET tube, yes, sir.
And were you able to maintain saturation, everything with that treatment?
Yes, sir. Yeah, with pediatric ET tube of size of 4 or 5. 4, I think 4 we use, 4 or 5. Because larger ET tube, adult ET tube will not pass that airway. So if you try to push that larger adult ET tube, you will lacerate the airway. And it will land, the patient will land up in all complications, sorts of complications. So once we know the CT that there was a critical narrowing, we measured the diameter, we put it in the 4-size tube, and through the tube, we were able to ventilate the patient.
And
so the saturation picked up.
Okay, fine. Okay. That was great.
And with 2 days, 3 days of treatment, his airway got better. We were able to extubate the patient. So these all things won't be available in local hospitals or in secondary or tertiary, because when all departments are there or when all consultants are around, it's easy. But if you're a single man or if you're working in a hospital where all specialties are not there, then if you have the clinical acumen, you should know when to refer the patient. One thing, you should know what all things should be done first. It's always an investigation of choice. never go after, in the first case, never go after the CBC, CRP, the old routine tests. You will be losing a lot of precious time. Because whenever a patient comes to the ER, everyone will send a CBC, CRP, sodium, potassium, and they will wait for the result to take a decision. But in patient with a respiratory distress, the blood parameters are not. Only one blood parameter is ABG. ABG you should be knowing. Then the other thing is, that is why you have to prioritize your investigation choice.
And the first case, what was the cause of sudden worsening of symptoms?
Yeah, sir. Actually, the patient was having a respiratory infection for 1 week, fever and cough. So this Hodgkin's tumor was there for quite some time. That is why he was having loss of weight for the past 3 months, where the mother was attributing to the hostel life. One thing. Second thing, since there was a respiratory infection, mucus plugging could have happened. Second thing, bronchoconstriction can happen, aggravated the procedure. Edema of the airways will happen. So it would have aggravated all things. And since he had received 1 dose of IV antibiotic, the casualty emergency doctor was saying it is anaphylaxis. So that is why adrenaline was given at first, but the patient was not responding. So we have to keep an open mind.
When we aspirate, if the patient coughs, does it mean that we have injured the lung?
What, sir? The second case. You're talking about the second case, sir?
No, generally, while aspiration, if the patient coughs.
Yeah, sir. When we aspirate, if the patient is coughing, what will happen? With every cough, the lung will expand. So if your needle is inside, it will injure the lung. But with a small bore needle, that injury, the lung will normally heal. But if you continue to aspirate, what will happen? Repeated injury will happen to the lung parenchyma and it will produce an air leak. So that is why when we say that when you aspirate, when the patient coughs, that is a sign that you should stop, or you should stop the aspiration, withdraw a needle a little bit out, maintaining the position. And if the patient settles, again, put in the needle and aspirate.
Where do you put the needle in pneumothorax? Is it second space on left side? Is it?
Yes, sir. So that is also a good question, that if it is a tension pneumothorax, usually the patient will be aspirated in semi-recumbent position or supine position. In supine or semi-recumbent position, the air tends to collect on the anterior aspect of the chest. That is why we always say that in tension pneumothorax, you have to put in a needle in the second intercostal space. It's known as a needle decompression technique. But for all other aspirations, we put the needle based on our ultrasound. We put the ultrasound, we know where the pleura is largely spaced from the thoracic wall, where there is no diaphragm, we put in the needle. So earlier it is a triangle of safety. We always teach our residents that there is a triangle of safety, you have to put in the needle in that. That is for all theoretical purpose. But from now, whatever we practice is we put the ultrasound, we scan the whole chest, we mark the position where the injury will be less to the pleura as well as to the other organs. But for a needle, for a tension pneumothorax, it is a second left intercostal space or second right intercostal space anteriorly, provided the patient should be semi-recumbent.
Thank you.
Okay, sir.
Any more questions? Then I invite Dr. Anand to propose the vote of thanks.
Thank you. Thank you, sir. Am I audible?
Yes.
Okay.
Thank you, Dr. Ajoy, for those very illustrious cases and going through the clinical intricacies in detail and stressing on the need for point of care ultrasound. Also followed by a very good discussion with interesting questions. I thank you all for the continued participation in the AMS ongoing academic activities. I'm looking forward to seeing you all again. Thanks, Dr. Pradeep, sir, again for another successful AMS evening.
So good night, everybody.
Okay, good night. Thank you, sir. Thank you.
See you all on 17th.
Yes, sir. Sure. Thank you.
Good night.